Hi, everyone, and thank you so much for joining us today. My name is Mayur Chandrayani, and I'm a senior consultant at Health Management Associates. In partnership with the California Department of Healthcare Services, or DHCS, I'd like to welcome you all to our third webinar in our Assertive Field-Based SUD Services, or AFBSS, webinar series. And now, I'd love to present it to our presenters today, Dr. Anika Alonso and Dr. Helen Duplessis.
I'm Anika Alvanzo. I am an internal medicine trained addiction medicine physician. I am based in Baltimore, Maryland. I have been boarded in addiction since 2010 and have worked at every level of the care continuum in the ASM criteria. So I'm very happy to be with you today.
Good morning. My name is Helen Duplessis. I'm a pediatrician in the Los Angeles office of HMA. Been with the organization a little under 6 years. And I got started working in perinatal substance use actually as a resident and did that for a number of years. And through the course of my career, I've had the opportunity to set up MAP programs in community clinic settings. And for the last actually, since I've been here at HMA, have been working in substance use disorder in California and in other states. And we're delighted to be here with you today. We have a lot to cover. So let's go on to the next slide and get going. Again, I want to encourage you to enter any questions or comments in the chat. We'll have the opportunity for Q&A at the end of our webinar, but we also can manage, Anika and I will sort of play off each other and manage the chat in the background as appropriate. So for today, our focus is going to be on, you thought you were going to get away from basic science. We're going to give you some information about brain changes and chronic substance use. We'll talk a lot about medication for addiction treatment, and then about the chronicity of addiction and the duration of treatment. And as mentioned, we'll have opportunity for some Q&A. On our learning objectives, we expect that by the end of the session today, you should be able to explain at least one of those brain changes that occurs with recurrent use of substances, that you'll be able to describe at least 3 benefits of the FDA-approved medications for opioid use disorder. You'll be able to compare and contrast at least one feature of each of those medications for alcohol use disorder, and then describe a couple of considerations related to duration of treatment for substance use disorder. So let's go ahead and get started. And I'll just pause, go ahead to the next slide. I'll just pause here and let you know you are about to learn more in the next 50 minutes or so than Anika and I learned in our entire medical school career, in our entire residency, and usually until much later than that. And part of that has to do with the fact that there has been, I see their hands clapping, but part of that has to do with the fact that there have been some really cataclysmic changes and advances in both our understanding and our ability to treat substance use disorder. So if you hear some excitement from us, that's why. We still have challenges, but there's just been so much advance in the last maybe 15 years or so. Let's go to the next slide. We're going to be talking a lot about dopamine today, and that's because it is really an amazing, naturally occurring chemical that's vital to our humanity. It acts in different ways in different parts of the body. So maybe you've heard about dopamine in the context of people who have heart problems, but it also acts in the brain as a really critical reward chemical that motivates us to do things that sustain our lives and is a really important way of generating positive feelings. So when we do things like eat or drink or have sex or just do our daily jobs or being in a relationship, all of that stimulates the production of dopamine in our brains. Let's go to the next slide. What we now understand is that dopamine, this amazing chemical, is one of the main neurotransmitters in the reward pathway in our brains. That pathway actually starts in the midbrain. So kind of imagine that area where there's some green and pink area in an area that we call the ventral tegmental area. And then it's got a pathway that goes to another nucleus in the brain. Some call that midbrain area the primitive brain because that's kind of where our survival reactions, that fight flight reaction, it generates. If that pathway is working properly, the midbrain then communicates with the prefrontal cortex, which is the thinking part of our brain. That's the part of our brain where we make judgments and decisions. It's where what we call executive function lives in our brain. But I'll pause here because I want you to understand that right now, we don't have a simple blood test that helps us measure the concentration of dopamine in the brain. Maybe not in my lifetime, maybe in your lifetime, we'll have that simple blood test. But what we do have is a ton of research that has been done primarily on animals and to some degree with some special scans where we can get a good sense of dopamine concentrations in the brain and how they are produced in that brain circuitry. So we know that on an average day, you and I get up, get in front of our computers or go to work, our brains are producing about 50 nanograms per deciliter. The units aren't really important, but average day, 50 nanograms per deciliter. On one of those days when we just don't want to get out of bed, want to pull the covers back over, don't feel like doing anything, our brains are producing maybe about 40 nanograms per deciliter, 40. Best day ever, you just launched your last adult child out of the home, you won the sweepstakes or you won the lottery, and you've got 1.5% body fat, brain's producing about 100 nanograms per deciliter. So normal range for the average human being is about 40 to 100 nanograms per deciliter. Now let's go to that next slide, because what we understand now is that when we use substances like alcohol or cannabis, our brains are kicking out about 500 to 600 nanograms per deciliter. Opioids, somewhere around 700 or 800 nanograms per deciliter. And you can see methamphetamine, which is the real bad actor, kicks out 1,100 nanograms per deciliter. So again, let's pause here for a moment because I got to remind you, 40 to 100 nanograms, normal range, methamphetamine, 1,100 nanograms. Now, as it happens, the human body does not like extremes, and it protects itself in various ways from being bombarded with those huge concentrations of dopamine. It protects itself in a variety of different ways. It changes the sensitivity of the receptors. It even kills off some of those receptors. That's a process called apoptosis. And let's go to the next slide. So one of the other things we understand now is that over time, because the brain doesn't like seeing those excessively high concentrations of dopamine, the amount of dopamine that is produced in your brain in response to substances decreases when you've been using for a while. It can decrease so much so, if you're following that orange part of the graph, that it gets to a place where it's below that normal range we were talking about. So you don't feel like getting up and doing anything. We refer to that as a dopamine depleted state. So there are a few things going on in our brain when we're struggling with substance use disorder. when we talk about cravings, what we're describing is those things that pull you toward behaviors or pull you toward a certain action. So in cravings with someone who has substance use, it's pulling you towards using that substance. And this diagram is really intended to kind of graphically depict the different intensity of craving that you feel under different circumstances. And we know this from experiments that have been done using functional MRIs, where we can actually image the brain and see the metabolic activity in the brain in response to various levels of craving and then being exposed to substances. So imagine, for example, we've done these experiments withholding water from individuals for, say, 2 or 3 days. And then we bring them into a room with a glass of water on the table, or maybe we pipe in the sound of rain. The intensity, the cravings that we see on those functional MRIs in the brain is about the size of those dried up raisins. Now, we've done these same experiments in individuals withholding food for, let's say, 3, 4, 5 days. And then we bring them into a room and we put a plate of food on the table, or maybe we waft in the smell of some fragrant food. And the intensity of the activity in the brain is about the relative size of those grapes that you see on this slide. Now, we've also done experiments with folks who have been on methamphetamine, and then they've been abstinent for, let's say, 30 days or maybe 60 days. And we bring them into a room and maybe we have some drug paraphernalia on the table, measuring again the functional activity in their brain. The intensity of that craving is about the size of an entire vineyard. So, relatively speaking, not only is that dopamine production excessive with methamphetamine, but with methamphetamine and other substances, the cravings that we feel, that part of the brain that gets stimulated, is also excessive. So let's go on to the next slide. And I just want to take a moment here and point out to you that we've already learned when you use substances for a long period of time, you can get to a place where you're in a dopamine depleted state because the brain's protecting itself from these high spikes of dopamine. Oh, by the way, that's also the reason why, you've heard people talk before about seeking that first high. The reason why you can't get back to that first high is because the brain is protecting itself. So we learned about a lack of dopamine. We understand now that that lack of dopamine is part of what stimulates these really intense cravings. And those cravings then push us to engage in behaviors that we normally wouldn't do because we're just trying to survive. We're just trying to really be able to live a decent life and get up and move around. We're in survival mode, right? Those behaviors, as atypical as they may be, in many respects are symptoms of this chronic disorder. And that's what people will often refer to as drug-seeking behavior. The other comment I want to make on this next slide is that, scientists have really extensively studied these reward pathways, this neural circuitry, if you will. And we now understand that the normal brain circuitry, that reward pathway, is dysregulated in people who have substance use disorder. That's why we understand this now as a chronic disease. Individuals with significant substance use disorder have significant dysregulation of these neural pathways, that neural circuitry. And let's go to the next slide, because with this dysregulation also comes changes in the brain that are both functional as well as structural. And those changes can last a very, very long time. We don't know precisely how long. We can't predict recovery times, but what you see on this particular slide is that on the top row, on the far left, is a functional MRI scan, again showing brain activity in a comparison subject who does not have substance use disorder. So you see the bright red activity. That's an indication that the brain is operating the way it's supposed to operate. And you can see about a month after cocaine use that brain activity is not lighting up in the same way on the functional MRI. And you can see again 3 months later, so 4 months after somebody's been on using cocaine, that brain activity is not yet even back to normal. On the bottom line, we're seeing that same kind of comparison with a methamphetamine user. So on the far left-hand side, a healthy person's brain. The second slide to the right is a methamphetamine user who's been abstinent now for a full month. And then on the far right-hand side, a methamphetamine user who's been abstinent for 14 months. And I should correct myself. So that first row, the second and third slides are that cocaine user who's been abstinent for a month and then abstinent for 4 months. So it takes the brain a while to recover. You can see that the brain is starting to recover, but functionally and structurally, we're not quite back to functioning in the absence of substance exposure. That also underscores why it's really critical for us to make sure that when we have somebody on a recovery pathway, that they're continuing that treatment to allow the brain that time to recover structurally and functionally.
In this section, we are going to talk about medications for addiction treatment. We can go to the next slide. And so in terms of the substances to which people can become addicted, there are 3 for which we have FDA-approved medications for treatment. That includes opioid use disorder, alcohol use disorder, and nicotine use disorder. Despite the outsized response we saw in terms of dopamine response from cocaine and methamphetamine, we do not have FDA-approved medications for stimulant use disorder, nor do we have FDA-approved medications for cannabis use disorder. And so we won't be talking about those today. Next slide. So we're going to start off talking about medications for opioid use disorder. You may hear people just say mood. So there are a number of benefits to these medications, including 1, they treat withdrawal. So we know that the experience of opioid withdrawal can be quite uncomfortable and is often a reason for people to return to use. And you can see there in the top bullet some of the symptoms that people experience in the setting of opioid withdrawal. And so these medications, particularly methadone and buprenorphine, which are 2 of the 3 medications, can treat opioid withdrawal. Additionally, Helen talked to us about the significant dopamine depletion that results with chronic use of substances that affects both the reward and motivation pathway and is chronic in terms of long-term disruption in both structure and function. Both methadone and buprenorphine, again, 2 of the 3 medications we have available for treatment of opioid use disorder, have some benefit in helping to restore that altered dopamine pathway and that depletion that occurs from chronic use of opioids. And then what we know is that they also improve substance use. So they treat OUD and achieve significant results. Overwhelmingly, the majority of people, up to 85% to 90% in some studies, will return to opioid use within 1 year in the absence of medication. And we know that in this era of high potency synthetic opioids like fentanyl and its analogs, that return to use can be fatal. In addition to reducing drug use and improving treatment engagement, the benefits of MOUD extend beyond. So, and we'll talk more about that on a later slide, but include decreased transmission of infectious diseases, decreased involvement in criminal activity, increased employment. And so there are a number of benefits for medications for opioid use disorder. Next slide. And so in terms of the approved medications, we've got agonist medications, and agonist medications turn on the receptor. The primary receptor in the brain is the opioid receptor that we're going to be talking about is the mu opioid receptor. Both methadone, which has been approved for treatment of OUD since 1972, so we have decades worth of data on the benefits of methadone, and buprenorphine, which has been approved for treatment for OUD since 2002. Turn on, they're agonist medications, so they turn on the receptor. And then our antagonist medications. Now, Trexone is the FDA-approved antagonist medication for ongoing treatment of opioid use disorder. And then we've got naloxone and nalmefene, which are also opioid antagonists. They are overdose reversal agents. And so an antagonist binds to the receptor, but does not turn it on. And typically has a higher affinity, thus blocking anything else from binding to the receptor when it's present. So we can go to the next slide. Okay, and I'm just going to walk through this slide here, just to kind of talking to you about a little bit about the pharmacology of each of the three different medications. So just to orient you to the slide, on the x-axis, as you go across from left to right, it's increasing dose of medication. And then on the y-axis, as you go from top to bottom, is increased activity at the receptor, at the mu opioid receptor. And so methadone, just like heroin or fentanyl or oxycodone, is a full agonist. So as you go across with, methadone is represented in blue. And so as you go across with increasing doses of methadone, you get increased activity at the mu opioid receptor. Buprenorphine, in contrast, is a partial agonist. And so buprenorphine is represented in that kind of goldish color. So what you see is that initially, as you increase the dose, you get increased activity at the receptor. However, there comes a point when even with increasing doses of the medication, you don't get additional activity at the receptor. And we call that a ceiling effect. That ceiling effect actually is why we say that that buprenorphine has a higher safety profile than methadone, because it has that ceiling effect. The thing to know, though, is that what happens when you've got a full agonist on board, and you introduce buprenorphine, again, which we'll show, has a higher affinity at the receptor. And so if you introduce buprenorphine when a full agonist is sitting on the receptor, that higher affinity means a higher attraction. So it's going to bind to the receptor, knocking off the full agonist that's there, and the gap between complete activation that you see with the blue versus the partial activation that you see with the gold is what causes withdrawal, precipitated withdrawal. And so the timing of when you initiate buprenorphine is going to be important. We want people to be in generally moderate withdrawal before initiating buprenorphine so that we don't precipitate withdrawal. And then finally, the antagonist, in that, what I like to say is more of a magenta color. That's going to be at the bottom again. So with increasing doses, you don't see any activity at the receptor. So it binds to the receptor, but it's not activating or turning on the receptor, which is again why it is not involved in kind of helping to restore the altered dopamine balance. Next slide. Okay, so we've got kind of an animation that we're going to use here to try to demonstrate to you how these medications work. And before we do our animation, I'm going to try to orient you to the slide. So we've got a neuron here, a brain cell. On the brain cell, you see those gray, kind of gray bars with kind of a semicircle at top. Those are the receptors, the mu opioid receptor. Again, the primary opioid receptor in the brain to which these either substances like heroin or fentanyl or these medications bind to. Methadone is represented by green. Fentanyl or heroin or oxycodone is represented by red. Buprenorphine is blue, and then kind of the gold pill-shaped images represent naltrexone. Okay, and then we're going to walk through what happens. So next we have methadone. It binds to the receptor, right? And as a full agonist, it turns on the receptor, right? Next, now because it's a full agonist, you can go to the next. When somebody uses on top of that, you can sometimes get additional activity at that receptor because you've got two full agonists binding to the receptor. Now, I will say, I have worked, part of what I've done in my career, I've also been an OTP medical director. And so we do know that methadone does provide some blockade as well. And so that is often how we determine how to dose methadone. Okay, next, we're going to look at buprenorphine. Okay, and so you can see the additional activation with the binding. So next, we're going to look at buprenorphine. So again, buprenorphine is a partial agonist. So it also activates the receptor, but not to the extent of the full activation that you see within a full opioid agonist. Now let's look what happens when when buprenorphine is introduced in the setting of a full agonist opioid on the receptor again. Yep. So again, that higher affinity or higher traction, it knocks off the fentanyl and it binds. But you can see, again, that difference in the degree of binding is why we time our initiation of buprenorphine so that we don't cause precipitated withdrawal. And then let's look at naltrexone, what happens. Again, our goal, naltrexone, binds to the receptor, but you don't see any activation. Next, again, naltrexone, naloxone, nalmefene also have a higher affinity at the receptor. Again, bumping off that full opioid agonist, which is, again, why we use these medications for overdose reversal, right? We want to get that fentanyl off the receptor and restore breathing. Okay, so that's just to give you an animation that I think hopefully helps you understand how those medications work, what's happening in the brain. Next slide. So now we're going to try to take a little deeper dive into each of the medications. And so we're going to start with methadone. So as we said, methadone is a full opioid agonist. There is no ceiling effect. And some people might need the full effect of methadone to make their cravings go away. It can be started while somebody's in withdrawal, so you don't have to wait for somebody to be in withdrawal to initiate methadone. However, because of the pharmacology of methadone, it is a much longer acting opioid than what you will see with heroin, fentanyl, oxycodone. And because it's much longer acting, we are more tenuous or more cautious in terms of how we titrate it up. And that results in it taking a longer time to achieve a therapeutic dose. What I will say is that recent federal changes in 2024 have made some changes into the potential starting dose for methadone, allowing for more flexibility for OTP practitioners to decide what starting dose to use, but it still takes a little bit longer to achieve therapeutic dose. Methadone does have more drug-drug interactions, and then methadone is very highly regulated. There's state-level regulation, federal regulation, DEA, SAMHSA, state licensing, and so very highly regulated and can only be given for treatment of OUD in the context of an opioid treatment program or narcotic treatment program, as referred to in California. If an emergency department provider, for example, wanted to prescribe methadone to initiate treatment of opioid use disorder, they can give no more than 3 days of medication. That's it. Right. So if you're starting medication and then allowing for linkage to an OTP, that's acceptable. Outside of that, methadone is not allowed to be prescribed for treatment of OUD. And then if there's a DEA licensed clinic or hospital and somebody's being treated for another condition, then that can allow treatment use of methadone, but otherwise, no. In terms of who might be best served by methadone, so methadone can be used for moderate or severe OUD, but patients with more severe OUD may actually benefit from methadone. We do know that while buprenorphine is very effective, it's not effective for everybody, and particularly, again, in the area of this high potency synthetic opioids in high dose high use of high-dose fentanyl, some people may need methadone to get effective control of their symptoms. Individuals who've not been able to achieve goals with other forms of MOUD. And then the other thing we should know about NTPs or OTPs is that they are required to have a number of other services. In addition to providing medication, they're required to have counseling, linkage and association with vocational services and other services. So people who might benefit from those additional supports that are present in an OTP or an NTP may also be individuals who might best benefit from methadone. Next slide. In terms of the federal regulations, again, very highly regulated, often delivered initially via observed dosing. Again, there were changes to federal regulations in terms of take-home doses and the number of take-home doses and how soon someone can get them. In February 24, SAMHSA made the COVID-19 flexibilities permanent, but generally individuals have to be fairly stable before they're given take-home doses, and that also varies by state. Again, highly monitored and have additional services that individuals may benefit from, including therapy, toxicology, vocational services, care coordination, etc. Next slide. What do we know about methadone? So I said it's the one that's been approved the longest. We have decades now of data to demonstrate the efficacy and effectiveness of methadone. It is highly effective. There was one study that looked at the reduction in opioid toxicology tests and found that there were 33% fewer opioid toxicology tests in the individuals who were receiving methadone as compared to individuals who were just receiving behavioral or psychosocial therapy. We know that people on methadone are 4 times more likely to stay in treatment. Again, and the benefits extend to decreased criminal activity, decreased transmission of HIV, hepatitis C, and importantly, methadone saves lives. There are 2 of the 3 medications have been found to have mortality benefits. Methadone is one of the 2. Individuals with OUD, 2 to 3 times less likely to die from an overdose when they are treated with methadone or buprenorphine as compared to no treatment at all. Next slide. Okay, buprenorphine. So buprenorphine, remember it was gold, it's the partial agonist. So it has a ceiling effect, which gives it a better safety profile. So again, with increasing doses, you don't get additional effects, and particularly you don't get respiratory effects, which is the concern when we're talking about using an opioid. It has, again, Helen at the beginning talked about a lot of advances. So there have been advances. So we had primarily sublingual or transmucosal buprenorphine, but more recently, we now have long-acting, either weekly or monthly injectable buprenorphine, which is just another option that's available for individuals, particularly individuals who are dealing with medical and psychosocial complexity. Again, because it has that higher attraction at the receptor, you have to be thoughtful about the timing for onset of buprenorphine and ideally wanting people to be in at least moderate withdrawal. The dose is important. A lot of the earlier research, people tended to be actually underdosed. So the literature suggests that the typical dose is going to be 16 milligrams or higher. Again, that has been tending to increase in this era of fentanyl. And it's important to know that both with methadone and buprenorphine, pregnant individuals later in their pregnancy are more likely to have to increase their dose and also increase the frequency of their dose. Buprenorphine has fewer drug-drug interactions than methadone. And so again, that also contributes to its higher safety profile. So who might best benefit from buprenorphine? Anybody who has moderate to severe opioid or mild moderate to severe opioid use disorder and or is in withdrawal. So again, both methadone and buprenorphine can be given to individuals who are in withdrawal and can be continued for ongoing treatment of opioid use disorder. And anybody who wants agonist treatment. Next slide. Similarly, just like we know that methadone is effective, buprenorphine is also very effective. So there was one study that looked at rate of return to opioid use for individuals on buprenorphine compared to placebo. 100% of the individuals on placebo returned to opioid use as compared to 25% of those who were given buprenorphine. Individuals on buprenorphine are almost 2 times more likely to stay in treatment. And just as we saw with methadone, buprenorphine has the same benefits with respect to engagement in criminal activity, decreased transmission of infectious disease, and buprenorphine also has the same mortality benefit. Next slide. Okay. And so naltrexone. So naltrexone, again, was represented by the magenta. It was that antagonist. So it is an antagonist with high competitive binding affinity. Again, it will, if something else is there, it will knock it off, which is, again, why we can use this class for opioid overdose reversal. Naltrexone does not treat withdrawal. In fact, somebody has to be through the withdrawal period before they can start naltrexone. So typically we tell people you need to be off all opioids 7 to 14 days, depending upon what opioid they were using, before they can start naltrexone. And to be honest, that is harder to do in non-controlled environments. So a lot of the literature from naltrexone comes from either residential treatment or individuals who were incarcerated because they were in controlled environments where they were not able less able, let's say, not going to say not able, because we know substances get in those environments as well, but less able to access. It's harder to do when somebody has regular daily access to abstain for 10 to 14 days before starting a medication. And naltrexone does not have the mortality benefit that both methadone and buprenorphine have. At least it's not been demonstrated yet. But there are individuals for whom naltrexone might be a good choice. So individuals who have maybe earlier in their course of use and have not gotten to the point of that profound dopamine depletion may be good candidates for naltrexone. We'll talk about next. Naltrexone is also used for alcohol use disorder. So people who have co-occurring opioid use disorder and alcohol use disorder, naltrexone may be a good option for them. Individuals who weren't able to achieve their treatment goals of one of the other 2 medications, individuals who may have been treated with methadone or buprenorphine for a long time and have decided that they want to discontinue those medications, but still want some protection. They might, after a period of time off of those medications, may start naltrexone. Or again, individuals who, after discontinuing methadone or buprenorphine, but know they're going into a high-risk situation, might consider using naltrexone in that situation. So going into a situation, going back for a family funeral, for example, and knowing that there are members of the family who are still engaged in active use, an individual might choose to use naltrexone to kind of give them additional protection in that setting. Next slide. So in terms of naltrexone, it is not, there are no federal regulations that inhibit its use. It's not, but some of the challenges, it's an intramuscular injection. So you have to have the staff to be able to do that. It's important to know that there are multiple formulations, both pills and injection. Only the injectable formulation is approved for opioid use disorder. Next slide. And just like the other 2 medications, naltrexone has been shown to both decrease opioid use, again, 90% abstinent toxicology test versus 35% in a study looking at comparing naltrexone to placebo, also associated with reduction in incarceration. And then was looking, it was studied in an HIV clinic and found, again, decreased opioid use in the individuals treated with naltrexone. Next slide. Okay. And then again, overdose reversal. So again, these medications are absolutely evidence-based medications for treatment of opioid use disorder, opioid overdose. And specifically what we know is that a lot of times an overdose occurs and naloxone is not present. And so this one study in DC, in 3/4 of the opioid-involved overdose deaths, naloxone was not administered. So the more naloxone we can get out there on the street, the more education we can do about the life-saving benefits of this medication. And it's important to know that in California, there's a Good Samaritan law so that people who are bystanders and in good faith administer naloxone in an attempt to reverse what they think is an overdose are protected. and it should be available over the counter. Next slide. Okay. This is just important for you all to know that there's funding in California for you all to, an organization to be able to get naloxone. You can get that through the naloxone distribution project portal. And then multiple counties actually have some maps that kind of give you an interactive guide in terms of how to access naloxone. Okay, alcohol. So alcohol is a legal substance and is the most used addictive substance. Worldwide, it's responsible for about 3 million deaths compared to about 600,000 drug-related deaths annually. 5% of all deaths can be attributed to alcohol consumption, whether it's a motor vehicle accident, whether it's the sequelae of alcohol consumption, but 5% of all deaths worldwide can be attributed to alcohol. And when people are having withdrawal in jail, alcohol is the substance that's most commonly involved with a withdrawal-related death in jails and detention centers. Next slide. In terms of emergency department visits, alcohol far and above is the substance that's most commonly associated with visits to an emergency department. In 2023, exceeded 3 million visits, which is like well over and above what we see for other substances. Next slide. In terms of the medications for alcohol use disorder, benefits decrease craving, reduction in drinking, and they have been found to be cost effective. Our 3 FDA-approved medications for alcohol use disorder are acamprosate, naltrexone, which we heard about before, and disulfiram. Next slide. So disulfiram is the first medication that we're going to talk about. You may be more familiar with it, with its brand name here, which is on this screen. The way disulfiram works is it interferes with how the body breaks down alcohol. And so it interrupts one of the enzyme pathways that occurs in the breakdown of alcohol, and you get a buildup of the toxic acetaldehyde, which results in all of the symptoms that you see on the screen. On the slide there. Very uncomfortable reaction. Next slide. In terms of what we know about disulfiram, so again, unfortunately, the data is not great in terms of the efficacy of disulfiram. Particularly, there was a Cochrane review that showed no difference between placebo. However, there are certain populations in which it has been shown to be effective, and that's individuals who are getting observed dosing. So, for example, individuals who were being treated with methadone, getting their methadone at the window and also their disulfiram at the window has been effective in those populations, or individuals who had a close family member or friend who was going to take on responsibility for assuming that the medication was taken. Outside of directly observed therapy, it is not really found to be efficacious. And there are a number of potential reasons that one might not choose this first line, as multiple drug-drug interactions. There are multiple contraindications that are listed here on the screen. It's important to know that the reaction that occurs is not isolated to alcohol that's ingested. So if people are using hand sanitizer that has a high alcohol content, they can potentially get a disulfiram reaction. And it's extensively metabolized. It has a list of side effects, and it also requires ongoing monitoring of the liver. And so this is no longer a first-line treatment. Next slide. Naltrexone. So naltrexone, you may say, well, I thought you said naltrexone was an opioid antagonist. Why are we using this for alcohol? Well, we actually think that the opioid system plays a role in the rewarding effects of alcohol. And so if you can block the opioid system, you potentially block the rewarding effects of alcohol. And that's the role for naltrexone in the treatment of alcohol use disorder. It is actually fairly safe medication, has few side effects. Certainly the contraindication is if somebody is already on opioids. So if they're receiving opioids for chronic pain, or they're already being treated with methadone or buprenorphine, naltrexone is not going to be an option for them. That is a contraindication, again, because of it puts people into withdrawal. It can be used in individuals with liver disease, including hepatitis, chronic hepatitis, including compensated cirrhosis. So the only real contraindication is liver failure or severe acute hepatitis. Well studied, safe, and highly underutilized, unfortunately. Next slide. In terms of the efficacy of naltrexone, been shown to decrease return to any drinking and decrease return to heavy drinking. And both the oral and the long-acting injectable formulations have been shown to benefit reduction in drinking. Next slide. And what do we know about extended release naltrexone? So again, that's that injectable formulation compared to other agents for alcohol use disorder. The outcomes tend to be better, particularly people who are on medication longer, and they have reductions in emergency department visits, hospitalizations, and healthcare costs, which is an important something to consider as well. Next slide. Acamprosate is the next medication. Acamprosate is works. Glutamate is the primary excitatory neurotransmitter. GABA is the primary inhibitory neurotransmitter in the brain. Alcohol binds to GABA, and which is why you get the sedating effect in the back. And alcohol also damps down glutamate. So what happens when you damp down glutamate, we said the body likes homeostasis. It likes to stay in the same state. So in the background, you're ramping up the glutamate receptors. And so when somebody stops using alcohol, they get this increased excitatory activity from glutamate. Acamprosate binds to the GABA receptors, or doesn't bind to them, but modulates them, has a response that's similar to GABA, and it's actually thought that it controls some of those protracted withdrawal symptoms, and it has been found to be effective. Next slide, which we'll look at. So effective in decreasing quantity and frequency of alcohol use and increasing increasing time in treatment. Challenge with acamprosate, it requires 3 times daily dosing, which is difficult for most people. I find it difficult to take something 3 times a day. If I get an infection and need an antibiotic, I'm missing one of those doses inevitably. And so that is one of the biggest challenges. But it is a safe medication. There aren't any drug interactions. You do need to adjust for if individuals have problems with their kidneys or kidney impairment. Next slide.
And let's just quickly come down the home stretch and talk a little bit about chronicity and prediction or lack thereof. Let's go to the next slide. We talked about this earlier. We talked about substance use disorder earlier as a chronic disease, and indeed it is. It's a chronic disease of dysregulation in all of those in that neurocircuitry and all of those great neuro modulating pathways in the brain. One of the things about comparing substance use disorder as a chronic disease to other chronic diseases like diabetes is there's a lot of overlap in the causes and what we can do to prevent and what we can do to treat both diseases. We've got medications and we've got lifestyle changes that work both in substance use and in diabetes. We've got behavior changes and changes in environment that work on prevention. But the attitudes and the consequences of those diseases couldn't be more different. I think we know how badly stigmatized and judged are our clients who have substance use disorder. Nobody judges or stigmatizes somebody who has diabetes. Maybe they might think something about their weight control, but not to the degree that they're stigmatized and judged in substance use disorder. And we all know the consequences of substance use disorder in terms of loss of parental rights and loss of employment and family and friends far outweigh any consequences related to diabetes. Then the big $64,000 question is the next one. How long do we treat somebody with opioid use disorder? And the real answer on the next slide is we can't predict accurately. However, you already understand there are these long-term structural and functional changes in the brain that take a while to get better. You also know that discontinuing medication sets you up for a return to use. And that for many individuals, and we all have stories about individuals who've quit using opioids, for example, and they've made it through and they've stayed on a recovery path. However, that's really, really rare. What we understand from the literature and from our own clinical experiences is for someone, for example, who has opioid use disorder and has been on a medication for opioid use disorder like buprenorphine or methadone, usually 3 years is the first period of time at which one might even consider discontinuing medication if discontinuation is something that's desired. And it's likely, and I think we've all had cases of individuals who seem to need those medications for far longer than that, maybe even for life. I think we all know, bottom line, recovery is possible, that for opioids and alcohol, we now have not only a whole lot of knowledge, but some incredibly effective medications, and that what you're doing, helping people enter and stay on recovery paths, and now expanded through assertive field-based initiation of treatment for high-risk populations, is really where we need to be, and really positioning folks to have the best chance possible of staying on that recovery path.
Thank you all so much for joining us today. Please remember we are here to support you. If you have any questions at all, please feel free to reach out to us at info@afbsstraining.org. Thank you so much and have a wonderful day.